Welcome to the Next 100. I'm Neil Fraser, President of Medtronic Canada, and I'm just absolutely honored to introduce two special guests today. First, Dr. Sacha Bhatia, who's the Executive Lead of Population Health and Value-Based Health Systems at Ontario Health, and previously led the Health System Solutions and Innovation Group at the Women's College Hospital. So welcome, Dr. Bhatia. And secondly, Dr. Sunny Malhotra, who is both a practicing cardiologist and an entrepreneur of RP Automation Systems. Welcome, Dr. Malhotra. We thought we would ask you each to talk a bit about how virtualization of care is leading to modernization of care.
Virtualization really is something that we've been talking about in healthcare for a really long time, but it really did take a pandemic to really create the impetus for change. Frankly, we've often had a fairly provider-centric system. And so, if you're a doctor and there's limited incentive for you to see patients through a variety of means, it's easy to just sort of fall into old habits and do, and do things the way you always have been. What's been really interesting about the pandemic is it fundamentally shifted something that we call the cost of contact. So the idea was, prior to the pandemic, there's always been costs of in-person care. Think about it. If you're a mom, with two kids and you're working, you have to figure out if you've got to go to an appointment, you've got to figure out childcare for your kids, you've got to be able to or take time off work, you've got to be able to travel to your doctor. There's a number of different costs that are there. Most of those costs were borne out by the patient, not necessarily by the provider. But with the pandemic, what we've actually seen is a shift in those costs because, when it was starting in March of 2020, fundamentally, you couldn't see as many people. You had significant risk both to other patients as well as to your staff and to yourself in terms of infection with COVID, costs of PPE, costs of testing, all these sorts of things that suddenly changed costs of increased cleaning. All of that added material costs to practices, hospitals, primary care clinics, other clinics, et cetera. And so suddenly virtualization became a really important mechanism within the pandemic to really be able to lower that cost of contact. In Ontario, where I practice, virtualization went from virtual care went from 1% of provider interactions to almost 70% of provider interactions almost overnight. And that did happen because the government decided to pay for virtual care and virtual visits. But it also happened, again, because of this impetus, because of the shift, in trying to keep patients safe.
Dr. Malhotra, you have a real interest in automating healthcare and in integrating data science and process optimization. Where is this at currently, and how do you see that moving ahead, maybe from a policy perspective as well as technology?
I think Dr. Bhatia brought up a very good point. Virtualization of healthcare right now has become more patient-focused. And we think about three different buckets, right? We've already had the infrastructure created, for example, in Ontario with Ontario Telemedicine Network. And bringing the care to the patient itself has been shown to be, provide a lower cost of care while also increasing access. And so the Virtual Care Task Force just came out with a report with a few recommendations about the virtualization of healthcare and how it should move forward in regards to policy and its reimbursement of it. Because if you can't reimburse the activity, then you run into challenges down the road. So there's three areas: connected care, making sure that the patient, no matter where they are, is connected. And we had some infrastructure that was built up before COVID, and then that allowed virtualization to occur. The second area is connect care anywhere, right? So if I can, make sure that the care is being provided from any place, and that the infrastructure, the internet, the Wi-Fi, whatever the case may be, is high enough quality that that care can be delivered. That's important. And then making sure that the care has networks. So the network effect of making sure that the care is delivered to the patients home or wherever they need to be, that's important to make sure that the quality of care is maintained long-term as well. That's a clinical side of the virtualization of healthcare, but I think there's also the administrative side that we've seen. There's the great resignation, there's the increased cost of admin, there's the resource allocation of nursing staff, for example, that have gone into clinical care and could not do as much administration. And so what you're going to see in the next 100 years is going to be an AI or automation strategy for a lot of these processes. And so what I mean by that is if 25 to 30% of your admin costs are going to delivery of healthcare, automating that using an AI strategy is something akin to what we've experienced 10 years ago, where we would say an EMR strategy was novel. But now the AI strategy, if you're going to look back another 100 years from now, you're going to say, how could I have ever practiced without an AI strategy or without an automation strategy? And so my area of focus is artificial intelligence and something called robotic process automation. There's not a lot. This is a novel form of AI and automation, whereby we use software robots to automate clinical processes and task flows by using software robots. And these software robots act like any full-time employee. They have metaphorical eyes where they can read an electronic medical record. They have, metaphorical brain, which we train and process. And then we have the third component, which is metaphorical hands. So they can enter in keystrokes as well as entering mouse clicks to automate a lot of the stuff that we'll see on the, front lines, which is, on an outpatient and an inpatient setting with the healthcare providers as well.
We hear about physician burnout, and is there the potential with automation and with virtualization that physicians, are connected all the time to their patients, and really deleterious to their well-being?
I think the short answer in what I've seen is yes, absolutely. I mean, I think you see data on physician burnout, and I've seen it actually in our own practices and on the front lines. And I think part of it is you're right. We connected everybody very fast, right? We suddenly went from a time when the idea of emailing your doctor or connecting through secure messaging was basically like almost unheard of in Canada anyways, to a time when in fact connectivity virtually was very ubiquitous. And that happened very, very quickly. And we didn't put in the right care processes and the right automation systems in order to do that. So as Dr. Malhotra, I think so aptly points out, what we saw was physicians getting called or getting messages for everything under the sun. Right? So everything from administrative tasks around medication refills to administrative questions around bookings to, a number of to serious medical questions, right? And the challenge is when you're a doc is it's like, and you get an email from a patient, the fact is it's there's a nervousness around not responding. And not responding in a timely manner. How long does it take? How long should I have? Now, different hospitals are developing policies around this. But the fact of the matter is there needs to be, a mechanism by which, urgent, you can triage and purely administrative tasks that should never go to the physician in the first place. They should go to an appropriate person. 2, there should be, a mechanism by which you can start to triage. And again, I'd love to get, Dr. Malhotra as an innovator. This is, I think, a great opportunity, is a way to triage the stuff that's non-urgent or can be more routinized. And then the things that truly are urgent that, need to be addressed in a relatively short period of time. So this is about developing new processes that I think will make this sustainable, which we haven't done yet.
And I guess, that it doesn't always need to be live, that you speak to a doctor. You could, you could do it asynchronously or offline so that, people could evaluate the urgency. And I imagine that's part of your technology, Dr. Malhotra.
Right. So, these software robots work whenever you want them to. They can be timed. They can work overnight. It's a virtual assistant essentially, right? I mean, it's a clinical virtual assistant. And so it works the same way any employee does, and it works behind your firewall. So you give it a username and password like you would an employee. It signs in, it logs in, it does the work. That's it. It's batch work, it gets it done, and then, it's ready for your clinician. There's attended and then there's unattended automation. Attended means that there's somebody there working with it during the time that it's doing the automation. And then unattended is it just does it on its own. And then afterwards, it's ready for you in the morning, by the time you need it.
Dr. Bhatia, you mentioned that we went from 1% to 70% virtual care, and most of it was telephone or like this, a Zoom call. But increasingly, patients have their own devices, whether it's a Apple Watch that detects AF or they may have other technologies at home. And this creates another challenge is how do you accept data from consumer devices and integrate this data into your analysis and action plan? Have you had any experience with that?
This is a huge issue at a policy level, right? So many of you, may know that Jane Philpott is leading a large piece of work for the government of Ontario called the Ontario Health, Data Platform or Ontario Health Data Council. I'm an ex officio member on that, as the Ontario Health representative. But it's an important endeavor, right? Because we've got to strike, Neil, an important balance between being able to provide data and integrate it, across multiplicity of like silos and providers if we're going to take on patients with chronic disease and manage them really well. And at the same time, recognize that we need to be able to protect privacy and security interests. And the challenge is I'm sure government doesn't always move that quickly. But the challenge is technology and technology companies now are moving at such a pace that it is a real challenge to be able to keep up. And I often say this, I said this before I moved into this new role. Right now, the vast majority of health data exists outside of the healthcare system. We give it freely. Like every time you have an Apple Watch, your oxygen saturation, your heart rate, you can do an ECG, there's, people have a blood pressure cuff and other peripherals that are connected to that. Even your preferences when you search on Amazon or Facebook, AI algorithms can tell a lot about you based on even just, your ordering preferences or the things that you share. And so, we're quickly moving into a world where the private sector is actually going to have more data about your health than we will as a publicly funded healthcare system. And so we're going to have to square this circle pretty quickly. Otherwise, we are going to become increasingly irrelevant. I think that that's an interesting challenge that we're presented with, but it's certainly something the government is very keen on trying to tackle.
We heard patients talking about access to their records involved photocopying, stacks of handwritten records. There's just backlogs of data like this. I don't know if it'll ever really be accessible.
Well, digitization was the first part for sure, right? Now we're in virtualization, and now we're going to have an AI strategy. I think automation will be part of that, and solving this interoperability issue is going to be very important.
The reality is patients actually don't need us to give them permission to have access to their own data. They can do it themselves. They can, as a patient at Women's College, as an example, I can get all of my downloaded, data from their patient portal, but it gets integrated, onto my Apple phone, right? Through, my health record. And I can start to integrate that across multiple providers. And so as a consequence, that integration is happening. And it's just not happening in our publicly funded system. And so this is why I say we have to get ahead. We have to think about this and tackle our approach to this fairly quickly, because if we sort of like in a fairly Canadian fashion sort of hum and haw about this and wait, the reality is it will have already been done. And so I do think this is where the government in Ontario is really thinking about this, and is with Dr. Philpott's leadership is driving this forward. Will be important from an innovation perspective, but I think most importantly it'll be important from a patient perspective.
So as we sort of move towards closing the discussion off, each of you, I'd be interested in your thoughts, getting back to the theme of the next 100 years. So thinking about where we are today, where are we going? Where do you see us maybe in the next 10 or beyond years?
I'll tell you where a lot of AI has been pushing as far as AI strategy is concerned. Okay. Clinical, administrative, and clinical is broken down into clinical delivery of care. So it's got to be omni-channel, procedural, and diagnostic. Okay. So I'll just talk about clinical for a second. Clinical, providing the omni-channel way of delivering care, we have the tools. Implementing that with policy changes is something that we're going to see or have seen already. Clinical, for diagnostic, a lot of people have been using CNNs or neural networks to evaluate images, tag them, similar to the way that we do autonomous driving. Tag them and say, okay, this is likely to be this type of diagnosis. So that's what you're going to see for diagnostics, whether they be radiology or if you're doing a colonoscopy, for example. There are tools that are software interfaces that are on top of doing a colonoscopy, saying this looks like a polyp, this has a certain percentage of being high grade, for example, or an echocardiogram. We're already working on it right now, and there are companies that are doing this in Canada and from Australia or from Y Combinator. Then there's a procedural component. Now that's where robotics, which is different than robotic process automation, gets involved. And you start to see where AI or manual manipulation of these sorts of things does procedures, and whether that happens in places where we don't have access or we don't have physicians, for example, it remains to be seen. But it is something that, Department of Defense and a lot of other, AI companies are working on. Administratively, I think that a lot of administrative work, interoperability solutions are going to be improved upon now and has been improving as we start to see an increasing percentage of penetration in the healthcare market of AI and robotic process automation. It started off around 11%. Now it's increasing, and there's a 41% cumulative annual gross rate for RPA implementation and AI implementation across North America. So you're going to see a lot of administrative work being automated, and you're going to see a lot lower cost of delivery of care when you bring the care to the patient, and when you automate a lot of the work or the administrative work that accounts for 25 to 35% of your clinical delivery cost. Those are going to be the areas, just in a kind of an algorithmic way of thinking, down the road in the next 100 years.
Listen, I'd like to thank both Dr. Bhatia and Dr. Malhotra for your excellent contributions to today and to our podcast series. And we really appreciate you joining us. And we'll wrap it up here. Thank you.